Welcome to the next webinar in the BHI Collaborative's Overcoming Obstacles series, Sustaining Behavioral Healthcare in Your Practice. This webinar is titled BHI in Practice, Establishing Efficient Workflows. Before we get started, please note that this webinar is for informational purposes only. You should consult a professional advisor for specific medical, legal, financial, or other advice. If you have questions or concerns, please send your inquiries to practice.sustainability@ama-assn.org. This series is a collective product of 8 of the nation's leading physician organizations dedicated to equipping physicians and their practices with the necessary knowledge to sustain a whole person, integrated, and equitable approach to physical, mental, and behavioral health care during the COVID-19 pandemic and beyond. This webinar will share how a psychiatrist and a family physician successfully integrated behavioral health care into their practice workflow to create a seamless experience for patients and their care teams. They will discuss how integration took place in a manner that supported efficiency and care quality while avoiding disruption to the practice operations. And with that, I will turn the conversation over to Health Management Associates Principal Dr. Lori Rainey and Medical Director of Integrated Care at Morris Hospital in Morris, Illinois, Dr. Jennifer Thomas.
Thank you, Becky. Our goal today, as Becky mentioned, is to talk about workflows for integrated care, efficient, successful workflows, and what that takes to get there. Next slide, please. When we think about workflows for integrated care, there are a lot of very specific tasks. And I think sometimes people don't really think about how much it takes to run this through your clinic. And I really think about the patient the day before they even show up. What's happening when the patient is in the parking lot? What's happening when the patient is in the waiting room and in the exam room? What happens when the PCP walks in? What happens with the screening tool? Who's entering what? So the devil is in the details here, and the minutia that is necessary to really do an effective implementation really requires the staff to sit down together and really go through this. So let's just think through this, and then you're going to see an example with Dr. Thomas of how she did this. So what are those core tasks that all of us have to do if we want to do integrated care? So the first piece of this, and I'm going to talk about integrated care, behavioral health into primary care. How do you identify the patients that are appropriate for integrated care? And who's making the diagnosis? So we often talk about screening tools, the PHQ-9 for depression, the GAD-7 for anxiety, maybe the Vanderbilt for children with attention deficit disorder. That screening tool is given either on a portal before the person gets in, on an iPad or a piece of paper. In my pediatrician's office for my daughter, it was a laminated form chained to the wall that the kids filled out and they wiped off between patients. But who's going to do that screening? Because this is how we have to find patients. In primary care, they don't always just walk in and say, hey, doc, I'm depressed. They come in and say, I'm tired, my tummy aches, my back aches, I can't get up in the morning, all kinds of different things. So how are we going to identify that patient? Who's going to hand out the screening tool? And then if that screening tool is positive, who's going to talk to that patient and see if there's a diagnosis that would be amenable to certain things like the collaborative care model of integration or someone needing brief therapy that's going to be coded and billed. So there has to be a diagnosis, and typically that's the PCP, but there could be a variety of different licensed folks that could do that. So how do you actually find the patients that are appropriate for integrated care? This is one of the second really important pieces, and we're going to talk a little bit more about this in a minute, is how do you engage the person? How do you talk to the person about behavioral health in a primary care setting? They didn't come in for that. They came in for a diabetes check. Now you want to, talk about depression. I'm not crazy. What do you mean, doc? And this is stigma and pushback can certainly happen. Well, the goal of the primary care provider in particular is, now that I've identified you, I want to engage you in the integration in our office. So in this picture up to the right, I want to figure out how to get that patient willing to talk to the behavioral health provider in the red sweater, and how does the PCP engage them? Once they're engaged, we want to provide evidence-based treatment. What does that look like? Brief intervention, psychopharmacology. So we've started that treatment. Now we have to have some form of systematic follow-up. We got to know when and where and how to adjust the treatment. And then when they're good, and they're ready to sort of come out of the integrated care program, how are we going to prevent them from relapsing back into it? Each one of these things is a very detailed piece of the workflow that we need to be thinking about. We need to figure out if integrated care isn't the right thing for them, then how are we going to coordinate and get them to a higher level of care, right? Because integrated care may not be the thing for them. They may have schizophrenia, be in a manic phase of bipolar, have complicated post-traumatic stress, things that just aren't necessarily going to work in the primary care clinic. Although I'll say, if we can do the common, less complex, treat those conditions in primary care, believe me, you're going to have a lot more access to specialty behavioral health, because I know how difficult that is right now. And then as we then begin to follow these patients, how do we review them? How do we make treatment adjustments? What does that look like? And then once we kind of get that done and we have all our data packed over to the right in our registry, so that's kind of a look at the registry on the right. How do we take that data, roll it into the program, share it with the PCP, share it with the C-suite, share it with the community? How do we share it with the patient? How do we kind of roll this data into our quality improvement program to really show that our integrated care is working? Next slide, please. So you can see there are quite a few tasks here. And I want to say, as you're assigning tasks, the important thing is that you're pretty clear about who does what. And you will hear me probably say this a couple times. It's not about Sue Jones is responsible for transferring the PHQ-9 score into EPIC. It's about the medical assistant, the receptionist, the nurse, the primary care provider. It's really about the role and who's going to do it. So it's not based on a person. You don't want integrated care to stop because someone gets sick, goes on maternity leave, goes on vacation. And it's like, well, we didn't enter the PHQ-9s because Sue went on vacation. It's like, that all your MAs go on vacation because it's an MA role to enter these PHQ-9 scores into the electronic health record. So we need to be very clear when we're going through the workflow, what role, there's person in it, but what role is going to be responsible for which of those pieces that I showed on the previous slide. Next slide, please. So as we're kind of going through the treatment, there's a lot that happens, and this could be diabetes, hypertension, arthritis, COPD, doesn't matter what the condition is, but we go through the traditional stuff, and our integrated care team is helping the PCP and the patient with all of these things. Are they adhering to the treatment plan? Have I reached the maximum dose of an antidepressant? Do I need to make a switch to another class? Do I need to call a psychiatrist to see whether or not, do I have access to a psychiatric consult to see if I should switch or augment or add or do something different? Or this patient only wants therapy, and this happens all the time in integrated OBGYN. Patients only want therapy, but they're not getting better. How do we start talking to them about medication? And then there has to be somebody who is actively repeating your measurement tool. We're not repeat screening. Sometimes people say we got to repeat screening. It's like, no, you screened once at the beginning. Now we actually need to measure progress. And if they're not getting better, have a conversation, get someone to help you, be that decision support in your EHR, be that call a psychiatric consultant or do an e-consult out to a psychiatric consultant if you have them. You may even have them there in your office. If people aren't getting better, what did we miss? Is the diagnosis correct or not? Maybe this is a bipolar depression. We thought it was unipolar. And then can we really do this in this office, or do we need to refer them? So these are the kinds of considerations that are going on in that course of treatment. And so they may require, that where in the workflow do I get a consultation if I need it? How long when are we supposed to repeat the PHQ-9? Is it once a week, once a month, once a year? When are we supposed to do this? So really kind of understanding those processes in the workflow. Next slide, please. The role of the primary care provider, as I mentioned earlier, is to identify the patients, diagnose them if you're comfortable. If not, you can always refer them to your integrated care team to confirm or help you with the diagnosis. There needs to be, sufficient knowledge of psychopharmacology. If we're really, trying to do integrated care and keep people from needing to be referred, what is it, what are your go-to medications and what are your go-to resources if you're not sure what to do next? The PCP needs to collaborate and consult with whoever that behavioral health provider is and with the psychiatric prescriber. So the gal in the red shirt in our initial slide, it's important that the PCP not say, I'm too busy to go grab the behavioral health provider. You really need that person in there and you got to go get them. We call it warm handoffs. They can be electronic handoffs. I'll show you a slide in a minute. The PCP needs to be looking at the measurement tools. You wouldn't treat diabetes without frequently looking at the A1C or even graphing the A1C and talking to the patient about their A1C or their blood pressure. Same for depression and anxiety. We're at the point in the field where you wouldn't treat depression or anxiety or attention deficit disorder without looking at the measurement tools over time. And so if you look in there and it's like, wait a minute, this patient hasn't had a PHQ-9 in 3 months, there's something wrong, calling the MA or sitting with the patient and quickly doing that are going to be important because you know the value of those tools in terms of driving care. So we need to just really kind of think about the roles of the primary care provider, and then the behavioral health person is going to whisk this patient away. You can go on and see a couple more patients, and hopefully it should make your day a lot more efficient. Sometimes it feels like it's going to slow you down, but it should make things a lot more efficient for you because once you do your piece, you can hand the person off. If you go to the next slide, just real quickly, I always want to help PCPs. You got to kind of develop your pitch to patients, because if you say, I think you have a mental illness and I've got a behavioral health, I got a therapist down the hall who can talk to you, hang on just a minute. A lot of patients are going to push back because of stigma, a variety of other reasons. But one of the first things you'll hear is, I don't need that, doc, I'm fine. And so using words like, we have a new way of providing health care at our clinic. I'm still going to be your eyes and ears. You're still going to come see me. I'm going to work on your medications, but I've got a behavioral care manager or a therapist who is a member of our team. Those are the words, not a therapist down the hall, but a member of our team who can help you improve your day-to-day function. They're experts in this. They're better than I am. They're going to communicate back to me. They're going to be my eyes and ears and boots on the ground. And so it's really important for you to work with him. I really, really, think this is best for you. What do you think? I want to set up some time, or you know what? She's right in the nurse's station. Can I grab her and you meet her? So the primary care provider's pitch is worth its weight in gold. And you may stumble over it the first couple times, and Dr. Thomas may talk about that, but you'll get it. You just have to be persistent. Next slide, please. I want to just kind of finish up with thinking about workflows, and Dr. Thomas is going to tell you specifically about hers. Our favorite is put a big old piece, like the middle, big old piece of sticky paper on the wall, get some markers, get some little sticky notes, and have at it. Start with the patient walking in the door, sitting in the parking lot, or the day before if you're going to push out a screening or measurement tool through the patient portal, through MyChart or something, and then put those sticky notes up there and mark. So you can move the sticky notes around, which is the fun part of it. It can then all go into a Visio diagram, which is this really fancy thing you see on the left. Once you get that all figured out, you can go to Visio. And with COVID, we've actually been doing workflows on Jamboard. I don't know if any of you have ever used that, but on the right, they're like sticky notes and you can actually move them around. Okay, next slide, please. I think we're gonna, as just a reminder, with COVID, we've done a lot of virtual integrated care. So adjusting these workflows was something we spent a lot of time on in 2020, and from the provider being virtual to the behavioral health person being virtual, the psychiatrists, we're always virtual. We tend not to be in there, the patients at home or in the office. I mean, everyone's been virtual. So I want to say, we stumbled at first because we weren't quite sure how to do it. We absolutely worked out virtual workflows. So with some of the stuff we've had around, COVID or even post-COVID, there is a way to do this virtually. So you don't have to always have that warm body behavioral health provider in your office. There are ways to work this out that are successful. Okay, thank you. I'm going to turn this over to my colleague, Dr. Thomas, to give you a real world example. Take it away.
Great. Thanks, Dr. Rainey. So happy to be here to share our workflow with collaborative care with this audience. So I'm a family physician. I'm 11 years out of residency. I work for a community-based hospital in Northern Illinois in a more rural setting in Morris Hospital. And I've kind of been our sort of grassroots champion of integrated care just by nature of the obstacle turning opportunity. Day after day in my office in primary care, we were just meeting that wall of there's definitely behavioral health conditions. My own knowledge and comfort was only so far with what I received in training. And that's when, behavioral health integration, when I started learning more about it and learning from colleagues like Dr. Rainey, it made sense to try implementing something that where we work. It's just a really powerful tool for us to do even better primary care to reach the patients where they're at. So if it's okay, I'm going to walk through a step-by-step. So door to door from a patient walking in our clinic, how we pull this off, who our care team members are, and how we make this happen. So next slide. All right, so this is our collaborative care workflow, and I'm not a tech savvy person. This is just me throwing down our thoughts on a PowerPoint. Our team got together and said, all right, we got to map this out. Like Dr. Rainey said, all of us had to sit down, define team roles, and then put it down on paper step by step. I'm a visual learner, and when I'm discussing this with my care team, I want us to all be able to reference this visual document to really conceptualize the steps involved to get everybody on the same page. That shared vision, making sure that everybody is on the same page with clear team roles has been the most important thing as we've implemented collaborative care. So starting from the beginning. So the PHQ-9, as Dr. Rainey mentioned, it's such a powerful tool for not only screening, but also measurement-based treatment to target. When I was taught how to do, depression and anxiety treatment as a family doc, in my training, we got training on the psychopharmacology of medications, but we never did that measurement-based piece. So early in my career, we would do follow-up visits and I'd say, how are you doing? And the patient would be like, yeah, I'm feeling better. And we'd kind of go, okay, I guess that's a win. But we didn't have that data, that objective measurement to help us know we were on the right track. So that's been one of the biggest practice transformation elements for me and in my health system is just getting very comfortable with using the PHQ-9. And it's now become something that is essential to us. We really look at it similar to a vital sign. Dr. Rainey used the blood pressure analogy. Your primary care doc is trained that if they walk in the room and they see a blood pressure that's elevated, it's 140/90, their clinical brain is going to go, oh, that's not good. That's something I need to adjust treatment for. The PHQ-9 is similar. We want patients to get used to taking that screener and for us as clinicians to look at the score to help us really drive treatment so that if someone's not improving, we can adjust treatment quickly and get them better quickly. So patient walks in the door. If they have not done a PHQ-9 screen within the past year, our receptionist will give them a paper copy of the PHQ-9. So also this element was incorporating universal screening for depression. We weren't doing that previously. So collaborative care helped us also beef up our game with just depression screening. When COVID hit, we had to switch to telemedicine. Our MAs switched to doing the PHQ-9 verbally. They would call the patient and get them ready in the Zoom room, and they would run through the verbal PHQ-9 questions. So we even made it work in the quick flip to telemedicine world. So the medical assistant would then enter the PHQ-9 score into the EMR. And this was an important step for our primary care docs, for them to have buy-in when we say, hey, we're going to do this extra step and measure depression with a PHQ-9 screener. You get some pushback of, well, that's going to take them more time and it's going to take them longer to get my patient ready to see me. So anything we can do to help get the PCP ready, everything locked and loaded, the MA can put in that numeric score. So with the PHQ-9, around 10 is where we're going to try to think of the patient that might be appropriate for collaborative care. Now, this is not a hard and fast rule. It does not replace clinician judgment. If you've got someone that scores an 8 and you know that they could use a behavioral health care manager and some input from the psych consultant, by all means refer. But in identifying that appropriate patient, 10 is kind of a good moderate depression score to kind of think of for who you're targeting for collaborative care. So then the PCP initiates their visit, and it could be in person or a virtual visit. They'll have their discussion and go through the criteria of major depressive disorder, or perhaps they're diagnosing generalized anxiety disorder, but they'll put in their assessment as they always do as the primary care clinician. Then the elevator speech comes in that Dr. Rainey was mentioning. And this is my biggest training point for my PCPs when we implement collaborative care is practicing so many times. We do in our sessions just a lot of run-throughs and dress rehearsals of how are you going to sell this to the patient? What are you going to say to them to get them engaged? So we really want to emphasize that this is one way that we can help address mental health conditions in our office. We're going to bring in 2 new care team members, a care manager. She works with me. She's down the hall. Her name's Christine, and she could come on in and meet you if you're interested in working this team-based approach. The other person we're going to have on the care team is a consulting psychiatrist. And if we get stuck where we're not sure if you're not, if you're getting better and if the medications are working, our psych consultant can come in and talk with us as a team to give us treatment recommendations to help make sure that we're getting you better as quickly as possible. We have some flyers with the little collaborative care triangle and handouts to say, okay, this is sort of the model we're following. And it's worked well to get patients engaged. And the feedback we get is a lot of patients love it. They don't love sometimes where they feel like their providers are siloed, where they go see a therapist in usual care and the PCP doesn't know what's going on with their care treatment, or perhaps a mental health specialist starts a medication, then they come see their PCP and the right hand doesn't know what the left hand is doing. So breaking down those silos and having everybody work together is a really effective and rewarding way to do behavioral health and primary care. So we do our pitch. Patient hopefully says, yes, that sounds great. I'd love to do collaborative care. If possible, we bring in our care manager into the room and do that warm handoff, that warm connection. It helps us develop rapport with the patient when we say, hey, I can vouch for Christine. She's my care manager. I work closely with her. She's part of my care team in my office. You'll be in good hands. And I think that helps patients feel even more engaged and comfortable with the process. So then I'll usually step out of the room, and like Dr. Rainey was saying, it helps me get through my day. I can go on to my next patient, and Christine, the care manager, can follow up with patient. Okay, do you have any questions about collaborative care? When would you like to come see me, the care manager, for a session? We can start doing some behavioral activation or some problem-solving therapy to address your depression. The care manager would then want to make sure to add the patient to the registry. So a registry can be a very simple, spreadsheet, patient names with the PHQ-9 scores. Centers of excellence like the University of Washington Ames Center have registry programs that you can use. That's how we do it at my site. We've been fortunate enough to partner with Ames Center for some research studies. So we use the Ames caseload tracker, and it helps us keep really good track of the patients so that hopefully people don't fall through the cracks, because we know in primary care, if someone comes in for depression and then never follows up, the doc may not have a way to think back and reach out to that person. So collaborative care is such a nice way to take that population based view of your care panel and say, hey, I can, make sure that some of these high needs, high risk folks are getting seen. So hopefully patient then leaves your office with feeling really great about collaborative care, and you may have started a medication that day, you might not have, but the care manager is then going to connect with that patient early. That early connection is really important for outcomes. So within 1 or 2 days, we're hoping to have a first session. And again, it could be an in-person session with the care manager, maybe a virtual. And they can start doing those brief behavioral interventions and the care management, where they might, send a message to the primary. Oh, that Zoloft, patient started, they had a side effect. What do you think? And then the care manager can reach back out with them for some reassurance and some coaching on how they can hopefully stay compliant with their medications. So the PHQ-9, this is another big culture shift that I know our site felt with doing collaborative care, was the sequential PHQ-9 measurement. So thinking of it again as that vital sign, that every time the patient would see me as a primary for med follow-up, and every time the patient would see the care manager for a session, we're all doing a PHQ-9. So similar to the blood pressure, we don't think twice about putting our arm out and getting a reading for a blood pressure visit. We really want to shift that transformation and culture shift of, okay, we expect a PHQ-9 every time. And, patients at first may have a little, why am I doing this again? I just did this last week with the care manager. But if we can, explain to them like, hey, this is our way to objectively measure that we're doing good care for you and getting you better as quick as possible. Patients really appreciate that we're taking that time and effort to be precise and objective in our care. So getting used to that is a little bit of a step, but now if I don't have it, if it gets missed and, I go into the room and there's not a PHQ-9, I notice, I'm like, oh, it's like, where's the blood pressure? Where's the PHQ-9 score? So it becomes second nature pretty quick, and it's nice. It's pretty effective. So from there, after the patient has their first session with the care manager and the site consultant will then review that list of patients in their weekly scheduled consult hour. So in my clinic, Christine and our consulting psychiatrists meet on Thursday afternoons. They have their 2 o'clock time slot, and every week they review the list of patients on their registry. They'll particularly highlight and discuss the new patients on the caseload or those that aren't improving. And how do we know who's not improving? Well, they have their PHQ-9 measurements. So it might be hey, this person's PHQ-9 score went up from a 12 when they were initially screened and enrolled in collaborative care to a 15 or a 20. What's going on with that person? Is there a new life stressor? Do we need to look at medication adjustment? And it helps them really be very purposeful in caring for that population of patients. So once they have their site consultant time, the site consultant will make their treatment recommendations and put a very brief note into the EMR. And the care manager then passes the ball and notifies the PCP. So your care manager would say, met with site consultant today. She's recommending we increase sertraline from 25 to 50, recommend problem-solving therapy. And so I'd receive that message as the primary care provider, and then I would prescribe those medications. The care manager then wraps it all together and says, okay, Dr. Thomas is increasing your sertraline. I'm going to do some problem-solving therapy with you, and they'll do that in their session. And it helps us all be on the same page, that there's one shared treatment plan, and that there's treatment goals. For depression, we really want to make sure that we're identifying treatment goals. If it's depression, perhaps the goal is, okay, I can return to work, that now the depression is getting better. Or with anxiety, it's something like maybe I can go to the grocery store, or I previously hadn't with the anxiety. The care manager can be very helpful in checking on medication compliance, but also then following up on those patient identified goals. And that's one of those cornerstone properties of the collaborative care model. And then for billing, the billing for the collaborative care codes is billed under the PCP. So if my patient is receiving collaborative care, care manager Christine is going to be tracking her minutes. So she'll have, when she gets to, it's like 70 minutes for the first calendar month, she can drop a collaborative care code. So that's a way that the clinic can not only deliver integrated care, but then bill for those services. And as far as payers and, which states cover, Medicaid covers the collaborative care codes, it's going to vary a bit by payer and by state, but those codes are out there, and it's definitely something to look into in your system for some financial sustainability to do this great work. Okay, next slide. Okay, so our key takeaways for integrated care implementation. We want to have our care teams define those key tasks and roles. As Dr. Rainey said, it's, the MA does this or the PCP does this, so that you can take that template and apply it to any primary care site where you're hoping to implement collaborative care. And everyone needs to see that document, discuss it, and digest it together so that everybody knows those clear team roles and what's expected of them and their colleagues. And have everyone participate in mapping it out. Maybe you do a lunch and learn and, buy a pizza and everybody comes in and talks through it, and we put up our, jam board or our Post-its and talk through it together. And again, one of the big points I would say is identify that PCP champion. They're going to be an important person to help other providers with uptake of collaborative care. If they can say, yeah, I tried this integrated care model and it helps me get my notes done quicker at the end of the day. I have less charting at home, or I feel less burnout because I have someone on my care team helping me with some of these complex behavioral health issues. And I have a psychiatrist that can help me with the medication if I, need some input for the challenging cases. It's a win-win, not only from the patient's standpoint, but from the providers too. And then meet with your team. If you can sit down with the care managers, the site consultants, the PCPs, all of you. I know with COVID, it gets challenging, even a virtual sit down, and talking through your workflow, because once you start doing this, you'll identify some areas of, we could tweak this or make this a little bit better. Or maybe we, label this message with a different title so that everybody knows, what we're looking for in the EMR. So those feedback sessions to evaluate your process are really valuable. But yeah, I think that's kind of our main takeaways. So Dr. Rainey, did you have anything else?
I was just going to add, if you don't have a care manager, still on the workflow Dr. Thomas showed earlier, even all the way to that point of measurement-based care is to have in your office a plan for, okay, well, I'm just going to repeat the PHQ-9 once a month, every visit, and I'm going to put that into the work plan so that the PCP is not having to do all that themselves. Even if I don't have all these other components, that is something you can do, like, again, measuring diabetes and hypertension, where you can have a way, an evidence-based way to track behavioral health conditions in your practice. So that would be another takeaway. If you don't have all of this, who would the key roles and tasks be for the folks that would provide, get those scores done so that you know what to do next? I also want to point out some resources for designing workflow. There's a nice link on the American Psychiatric Association website if you go to the Practice and Billing Toolkit, and also University of Washington Ames Center has a really nice workflow checklist where you check the items and you put the role, the name in, the role in, so that you know exactly what's going to happen step by step. Okay, thank you.
Thank you, Dr. Rainey and Dr. Thomas, for sharing your expertise and experience with our viewers. Be sure to visit our series page on the AMA website for more information on upcoming releases. You can also access previous recordings on your YouTube playlist. Please also check out the Collaborative's resource, the BHI Compendium, for a helpful framework on how you can make BHI effective in your practice.